excuse me, we are going to go over some hematology. And to begin, we will talk about circulatory disturbances. So this is going to involve any abnormality or alteration to the flow of blood to various organs of the body. So for this lecture, I'm going to start out with some basics of thrombi formation, and then I'll make a subsequent video after. So that being said, I'm going to begin with the development of a thrombus and distinguish that from a typical clot. So we'll talk about how thrombi formation is different in the venous system versus the arterial system. One is a little bit more detrimental to the physiology and anatomy of a human, and it really just has to do with the anatomy and the size of the vessels. And then we'll talk about predisposing factors to creating a thrombus, or an intravascular clot is another term we use for them. And a term that you should know in pathology is an embolus. And an embolus is defined as anything really flowing through the bloodstream that's not technically supposed to be there. So that can be a collection of cells, like tumors move via embolism. If it's a portion of a clot that breaks off, it moves. We call that an embolus, and its moving is by embolism. And there's also different types of emboli, like foreign bodies, fat, amniotic material, air. And those things are going to follow the typical blood flow that you would expect with regards to the pulmonary arterial circulation and then the portal circulation. So knowing that circulatory pathway will be really important to understanding the outcomes in patients when there is a thrombus that develops. And then we'll go on to a really important part in pathology called infarct. And an infarct is referred to as a portion of necrosis, or the development of tissue death, in response to ischemia. And when there is infarct, there's going to be different symptoms depending on which tissue it's in. All tissues have their own ability to withstand infarct and ischemia. And then there's some ways to treat that. Sometimes these changes will progress to an irreversible level, but in tissues like the heart, there's about a 20-minute window to restore blood flow and limit damage. So that being said, we'll start out with thrombosis in this lecture. And thrombosis, thrombo is the pathological term for clot, and osis means the development of. So the development of a clot. And a thrombus is different than a clot, because a clot is something that would form in actual response to a tissue injury. And when I say tissue injury, I mean a tissue that's been torn and the contents are then exposed to air. In thrombosis, it's not going to be visible from the outside. This is actually a picture from a veterinary surgery. So this is from a German Shepherd. They get the same type of thrombus development that humans do, and they're treated similarly. And what I want you to notice is that within this artery, it's impossible really to tell from the outside that there's anything abnormal going on. You'll probably hear the term Doppler, and a Doppler refers to using sound waves to identify any abnormalities in flow. So you can use these Doppler paradigms to see if there's any abnormality. And what they've detected is that there's abnormality in flow in this artery, which is not evident from the outset. But once you open up that vessel, you find this really interesting organized mass of cell components referred to as an intravascular clot or a thrombus. So this is different than a clot you would see forming because you've cut yourself and you want to limit blood from leaving the circulation. A thrombus is an intravascular clot that maintains a site of connection to the blood vessel wall. So that being said, here is a typical injury to a vessel. So the vessel is torn, and then that's going to give some exposure to, or of the contents to air. In order to limit this blood leaving the circulation, there is the initiation of the coagulation cascade to form a clot. And as you might remember, the end result of the coagulation cascade is the formation of these fibrin filaments, which are really strong. They're hard to pull apart. They're made of collagen, and they form a net. And fibrin will be able to be sticky enough to take anything in that area and pack it into this site of leaking that would lead to blood loss. So it's an adaptable change that we see in response to physical injury and danger of blood loss, and we would want that to happen. However, in a thrombus, we see that the same process is initiated. However, there's an absence of tissue injury, meaning that the vessel has not been torn and exposed to air. Instead, there is a small amount of damage to the lining of a vessel, and we've initiated the coagulation cascade to start growing a clot inside of a vessel. So it's a much different process, and it's not as advantageous. We're not in danger of losing blood this way. The body just believes that it is. So in learning the rules between a thrombus or an intravascular clot versus a typical clot that would be in response to injury, some rules exist. So first of all, a thrombus never forms outside of a blood vessel. So just like you saw in that picture on the previous slide, you can't see them from the outside. They can only be detected using certain tests. Whereas a clot, you would see that from the outside, and it would be sealing up like a piece of duct tape, limiting any damage and blood loss. So they don't form outside. They are solely inside a vessel, which is why we refer to them as intravascular. And once a thrombus grows, whoa, that went rogue for a second. It maintains a site of attachment to the vessel wall. So it will activate the coagulation cascade, the clot will start to build, and unless something knocks it off, it's going to maintain that attachment. A clot, again, it is going to involve a multitude of steps that result in the creation of fibrin strands that trap formed elements in this open spot to limit blood loss, whereas a thrombus, it's not just this disorganized mass of components in that area. Instead, it is a very calculated, organized layering of blood components that are formed via a portion of the coagulation cascade. The most important, though, is that with a clot, there is physical injury. There's physical tearing of a vessel and danger of blood loss. In the creation of a thrombus, there is no tearing of the vessel and no danger of blood loss. However, there's still an activation of the coagulation cascade. You might remember from your anatomy and physiology classes that organs and tissues are rich in a factor called tissue factor. The full name of it is thromboplastin. It's factor 3 in the coagulation cascade. And when there's physical exposure of the underlying membrane of the endothelium, called the basement membrane, to the rest of the body, there's the expression of tissue factor. And tissue factor really helps to initiate the coagulation cascade. One of the problems with tissue factor is that it is really high in organs in general. So when there is organ damage due to infarct, there will be a really high expression of tissue factor, which will initiate the coagulation cascade. So what you're looking at here is the second part of the coagulation cascade. The different pieces, they go in alphabetical order. So the first steps are called the extrinsic pathway, and the second pathway is called the intrinsic pathway. And the reason why they're called that is for the location of the variety of substances needed to create the clot. Extrinsic means that the the ingredients that are needed to form it are located outside of the blood vessels, where the intrinsic pathway involves things that are locally in that area. So in thrombus formation, we begin with a rogue factor, factor 12, which is referred to as the HAGEMAN factor. And HAGEMAN factor can initiate the intrinsic pathway, which would normally in injury only be initiated when there's a really strong stimulus from the extrinsic pathway that would be triggered in tissue damage. However, HAGEMAN factor, factor 12, can do the same thing by coming in and cleaving factor 11, which then activates factor 9, and then co-activates factors 8 and 5, so that we have the activation of factor 10. Once factor 10 is activated, we refer to everything after that as the final common pathway, because regardless of the intrinsic or extrinsic pathway, once factor 10 is activated, it cleaves the substance prothrombin into thrombin, and thrombin, which exists in a burst, it really is a positive feedback, and it can activate many strands of fibrinogen. What thrombin does is cleave fibrinogen into component pieces called fibrin. And fibrin is your net that's used to capture blood components and then put them into the space where blood would be lost. And this, when everything is working properly, it works together with the intrinsic pathway so that there's a really great clot, there's good coagulation, which is referring to the stasis or limiting of progression of blood loss. So thrombus formation is going to begin at the level where there is going to be, instead of damage, just exposure of the subendothelial levels to the rest of the bloodstream. And a rogue factor 12 is going to activate the extrinsic cascade, essentially tricking the vessel into believing that it's in danger of bleeding out. And then we're going to start to build a clot in the same way that we would in a normal clot cascade. So what you see in a thrombus, again, isn't going to be this just mass of whatever's in the area caught in a fibrin net and just packed into this open defect in the vessel wall. A thrombus is a highly organized level or layer of components. So in thrombus development, this arrow is pointing to some white areas, which are layers of fibrin. And these are called the lines of Zahn, Z-A-H-N. And the more fibrin there is in a thrombus, the more stable that thrombus is. So you'll hear terms like stable angina, unstable angina. Same thing with clots. There's stable clots and unstable clots. And if a clot is stable, that means that it's really well adhered to the vessel wall and it's probably not going anywhere. So these fibrin walls, fibrin is scar tissue. It's really strong. It has a high tensile strength, which means it's difficult to pull the strands apart. And the more fibrin lines there are, the stronger that clot is adhered and the less likely it is to move. And what you're looking at here in this picture, we have a vessel with its muscular layer, its adventitious layer, and everything in white here is fibrin. The darker red areas are just blood components. And when this activation occurs, it's a very minute activation of the coagulation cascade. Platelets start to stick there. Platelets call more platelets, and then platelets help make more fibrin. So you'll see alternating layers of platelets, fibrin, kind of like a layer cake, only not very delicious. So a thrombus can occur in any vessel or within the heart in the case that there's stasis of blood flow. You'll see this in individuals who have valvular abnormalities. So for example, atrial fibrillation is usually not that big of a deal. It's just a quivering of the atria. But blood can pool and stagnate, and when blood stagnates, it coagulates, which means you can see intravascular clots forming on the atrial appendages. So really anywhere in a vessel or within the heart, you can see these intravascular clots develop. Again, we refer to things moving in the bloodstream as emboli, for plural. An embolus is singular, and a thromboembolus is a detached portion of a clot that, depending on its location, will be carried either through the pulmonary circulation, in the venous system, or the arterial system. So one thing that you should keep in mind, this is a learning objective, which means it's important. In the arterial system, there's a couple of things that naturally are going to limit the growth of thrombi. The flow in arterial systems is very fast, it's a high pressure, and literally as a clot, an intravascular clot is forming, when platelets are activated, the fibrin is really washed away. So that limits their growth and their size. Another really important thing about the arterial system is that it's really big vessels. So if you think of the aorta, for example, the aorta is the biggest artery in the body. Those are really big, and then they branch into smaller segments. So if there's a piece of a clot that in the arterial system breaks off and then moves through an embolus process, through an embolism, it's going to get lodged in a branch system, which means that anything distal to that area of impaction is going to perhaps infarct, but that's not going to hopefully lead to immediate death. If this, for example, was in your hand and you had tiny vessels that are blocked, it might cause some tissue damage to the distal fingertips. However, it wouldn't kill you. What is dangerous is in the venous system, because the venous system is going in converging directions. So rather than going big to small, everything in the venous system is being conveyed to the vena cavas, which are huge and they're low pressure, and it's easy for things to grow in them. And it's way easier for clots to grow larger in the venous system because the flow is so slow and the pressure is low. So that means they can really get large. Excuse me. And then once we get from the vena cavas into the heart, those big valves, they're big. You can fit really large clots through those areas in the heart. And it's really when they get to the pulmonary vessels or to the lungs themselves that they get lodged and can cause death almost immediately or really profound symptoms. So in general, I want you to know that venous emboli and venous thrombi are far more dangerous than arterial. And here's a picture showing you the difference between arterial and venous thrombi. So here is an arterial thrombus. So when it is activated to start to grow, again, it's going to be caused by just a slight injury to the lining of the vessel, an exposure of the subendothelial layers to the vessel. Then we activate the intrinsic cascade with the HAGEMAN factor. So platelets come and they bind, they're activated, and they make fibrin. And then more platelets come. And then more fibrin. And then platelets, fibrin, platelets, fibrin. Which means there's a lot of fibrin in arterial vessels. And as they start to grow larger, because the pressure is so high and the flow is so quick, it washes away the fibrin formation so that it physically limits the size of the thrombus. So in the arterial system, there tends to be more stable thrombi with more lines of Zahn, and they tend to be smaller. If they do detach, they get caught in smaller areas with less detrimental effects. Conversely, in veins, the flow is really slow. This coagulation cascade is activated. There's some fibrin and lines of Zahn, but because blood flows so slowly in veins, once this develops, it just starts developing into coagulated blood. And that's something called the red cap. The red cap has no fibrin associated with it. That means that in the venous system, these thrombi can grow really large, and without the stability of the fibrin, these pieces, such as the red cap, are more likely to break off and then traverse the system. they will eventually go through the vena cavas to the heart and the lungs, which is going to be a really dangerous scenario with the health of the patients. So that's my quick primer on